That was a really great discussion. Thanks. And I'm sure that we'll have more comments about the role of medical therapy and then the great work that's been done, obviously, in your heart failure clinic and just making sure that we have compliance. If we're talking about adding a little bit of real estate to the portfolio with mitral, we're heading full blown into emerging markets now. So really to kind of begin the discussion with regards to that, we'll turn over to Matt Suffoletto, percutaneous tricuspid valve repair, making it a reality.
Okay, greetings everyone. Thanks for having me. Really excited to give this talk. I have no disclosures. We will be discussing, though, an investigational device that we've been using at Presby, the TriClip. I'm going to be showing some pictures. So we all in this room know tricuspid regurgitation is prevalent. It's prognostically significant. This is a higher risk surgical cohort by the time this is diagnosed, perhaps because of late discovery or patients' comorbidities. And in the percutaneous space right now, we have only investigational devices. We don't have an FDA-approved device. But as we've shifted our focus to percutaneous approaches to the tricuspid valve, we've really seen a paradigm shift as far as how we image the tricuspid valve. So for this talk, I'm going to be reviewing tricuspid leaflet anatomy as it pertains to percutaneous solutions for tricuspid regurgitation. We're going to talk about how to assess severe TR, discuss briefly the types of functional degeneration, and talk about some of the echo considerations as we approach percutaneous solutions to the tricuspid valve, tricuspid regurgitation. This is Rebecca Hahn. She is really a thought leader in our field. I'm showing this paper because if you are an imager, if you have any interest in learning how to image the tricuspid valve, she is a really important figure and a real Jedi master of the tricuspid valve. Extending that analogy, I'm showing my partner, Bill Katz. We're the imagers as part of our tricuspid program, and we are aspiring to Jedi masterdom there. This is who I was when Bill first handed me a probe in the early 2000s when I was a fellow, and I realized that this is what I've become. This is where we are now. And again, extending that analogy, let's talk about our tricuspid valve team. We have Dr. Conrad Smith, our interventionalist. Never tell him the odds. Jeff, I took Luke, so you know who you are. Chewbacca. And also a couple of our other structural imagers, Josh Levinson, who's in the crowd, Dr. Zach Reinhardt. I wanted to call attention to them. Because of the limitations of the protocol, they are not our active imagers for our tricuspid program, but they participate in our heart team waking up for a 6:30 meeting every Thursday, so they deserve a little bit of attention too. And last but not least, PA, Katie Fatiganti, who's in the audience. You might not even know who this is, Katie. This might be before your time, but you really are rounding out the cockpit here with us. So jumping right in, let's activate the hyperdrive and advance my slide. So tricuspid regurgitation, it's prevalent. It's prevalent in our elderly population. We see a higher prevalence with the diseases we know well, our patients with atrial fibrillation, our patients with pacemaker leads, the patients treated for their left-sided valve disease, either surgically or percutaneously. And we're plagued by late detection for a lot of different reasons. And this might be because tricuspid regurgitation may be clinically silent early. We might not be good at detecting it in the echo lab, but that's a whole nother subject and really deserves some attention, both from a sonographer and imager level. And by the time we discover it, there's often entrenched comorbidities, long-standing atrial fibrillation, right-sided heart failure, pacemaker lead present, kidney disease, liver disease, as we all know. I'm going to briefly, I'm going to skip over that. That's a topic for another discussion, but severe TR, know it when you see it, and even aside from some of the real sophisticated quantitative methods or 3D imaging we use, if you are seeing, where's my marker there? If you're seeing reversal in the hepatic veins, if you're seeing a really triangular, dense tricuspid signal, if you're seeing a big right atrium and a big IVC without the, another reason for it being there, like an ASD, you should really be paying attention and looking for the tricuspid regurgitation. We have really sophisticated quantitative methods. I remember as a fellow when I learned PISA, I said, oh my God, this is so abstract and academic. Why are we ever going to use this? Well, we are using PISA and PISA ratings. It's really entered the lexicon. Even our interventionalists know what PISA is and talk about the PISA dome and baseline shift as we're imaging. So severe TR, know it when you see it. This is one of our patients. We see here on the upper right screen, a very dense triangular tricuspid regurgitation signal. We see a PISA dome flow convergence indicating a high volume regurgitation jet, and we're seeing on the bottom part of our slide there, hepatic vein reversal. And Let's try my other slide advance. So we have quantitative methods to say what is severe TR. When we're talking about percutaneous solutions for the tricuspid valve, tricuspid regurgitation, this is the criteria used in the Triluminate trial. Notice we have two additional categories here. We have created massive TR and torrential TR. We needed these both for descriptive purposes because we know that there are patients who have severe plus and severe plus MR. But we also needed to monitor this because with our percutaneous approaches, we might not reduce below severe, but we might reduce to a lower grade of severe, so it helps to have a descriptive framework. Now, this may be obvious to the surgeons in the room, but even to people who've made their career imaging, tricuspid valve anatomy is variable. We've traditionally learned this is a 3-leaflet valve, but actually now with imaging, we're realizing that there's quadricuspid valves and even quintucuspid valves out there. And really, even with very high-quality TE techniques, when we're using a planar imaging technique, it's really hard. It's like the fundoscopic exam. You know, until we had a technique like 3D echo to really see all these leaflets laid out in a single plane or the surgeon's view, we really didn't appreciate the variations in anatomy, which I'm showing there. This is a couple of the techniques we use in the TE lab, and this was procedural planning for this patient. On the left side of the screen, I'm showing 3D MPR, that's multiplane reconstruction. This is really a workhorse concept for us, both pre-procedure and during procedure. We're using a 3D data set and using steerable planes to evaluate the valve at different levels. And if you look on the left side of the screen, if you look at our middle view here, you might appreciate there that this is a quadricuspid valve. It has a very diminutive posterior leaflet as well as a larger posterior leaflet, larger, thicker. The anterior leaflet is down in the 4 to 6 o'clock position in our septal leaflet, and that's obviously going to impact our approach, particularly when we're talking about an edge-to-edge repair. This exact patient, the analogous view, this is a transgastric 30-degree view we do from the stomach. A lot of people have learned this view. But notice in this same patient, we don't quite have the appreciation of that fourth posterior leaflet there. So even though this is a useful view, I think with the MPR, when we can do it well, we get a lot of additional information. And this is kind of a tilted anatomy. This would be a type 3B valve. I don't use that, but we see 2 posterior leaflets, so I think it's a useful discussion. We can apply color Doppler techniques to these same 2 views, and I think that's very helpful both for procedural planning and grading severity of TR. We can get these views even with 2D, with transthoracic techniques. This is a transthoracic image taken from our lab in one of our Triluminate enrolled patients here. So even with a really high quality, a 3D probe and high quality transthoracic imaging, we can get this same kind of surgical type view. When we talk about tricuspid regurgitation, there are causes of primary tricuspid regurgitation I have listed there, but oftentimes the majority of our patients are patients who have secondary tricuspid regurgitation, and we lump this into categories atrial functional, ventricular functional, and also pacemaker associated. And it's important to note that really these can coexist. We can have, by the time our patients come to us, they may have both atrial functional plus a pacemaker lead. They may have a component of leaflet tethering because of RV remodeling as well. So really there's going to be some overlap. But these are broad categories that I think help the discussion. This is a patient of ours we ended up implanting as part of the Triluminate trial, and this was a patient with primary myxomatous degeneration, but probably also some annular dilation by the time she came to us. We see thickened myxomatous tricuspid leaflets as well as mitral leaflets there. This is a functional ventricular regurgitation. I think on the right side of the screen with the absence of tissue Doppler, you see that we have apically tethered tricuspid leaflets with a wide tricuspid regurgitation gap. And that same patient using a 3D technique, this patient also had a pacemaker lead. It may be a little difficult to appreciate. I don't think I have a really great functioning pointer here, but this patient has a pacemaker lead in the kind of 7 o'clock position that we see on the left side of our screen. Now that pacemaker lead, though it may have some interaction with the posterior leaflet, look at the coaptation gap and look at our far away from that, the anterior leaflet and the septal leaflet are not coapting. So this is a pacemaker that probably has little functional significance to the degree of TR that this patient has. Atrial functional, we see effacement of the tricuspid leaflets, a really broad annulus and a regurgitation jet. Briefly, pacemaker leads. We have encountered them. We know that they can have leaflet interactions. We know they can also cause leaflet injury and fibrosis. It's now, pretty widely accepted that even if you detect this and their pacemaker lead is interfering, pacemaker lead removal is a morbid, complicated proposition, and also that fibrotic lead injury doesn't go away when we remove the pacemaker lead, if that was the cause. And just some imaging here. This is clearly a pacemaker lead interacting with our septal leaflet. I think that the lower left panel shows it best, but we can also use a sophisticated 3D transthoracic technique as well to really understand how that leaflet, the bright spot in the lower right corner, is right pinned against the septal leaflet and holding it back. Large coaptation gaps, we've had to be able to assess and address these, describe them to our heart team and our interventionists, and know that this is a complex proposition, particularly when we're talking about edge-to-edge repair. Our experience, just to briefly summarize, we have implanted 21 patients as part of the Trilumina trial with a tricuspid tier approach. Pacemaker leads were present in a number of these, and we've had some successes even with the pacemaker leads being present. Challenges we faced, and I hope during the discussion we can talk about this a little bit more. Large gaps, flail septal or posterior leaflets have proved challenging. Flail small leaflets, fibrotic chordae, ventricular tethering as far as getting purchase and getting a nice grasp on the leaflet. And of course, cases where we have suboptimal visualization, we're not able to create those beautiful MPR slides. Much like in the mitral space, we've talked about kind of green light, yellow light, red light. So there is guidance out there in the literature to say, who is going to be a successful candidate, who's going to be a more challenging candidate, and who is a candidate for tricuspid edge-to-edge repair that we should probably avoid doing. I don't think I have time to go into this case. This is a case that Jeff, we talked about, and he urged me to present. This was a quadricuspid valve. We put 2 clips on. I'm just going to, in the interest of time, show kind of the money slides here. So this is us in the intervention using MPR to guide our clip placement. This is our first clip. We're trying to get a nice septal anterior grasp here. Then we shift to X-plane, which shows us the grasping view on the right side of the screen really well. This is our grasp, clasp, and release on the right side. Got a nice result. First clip in place. On the right side of the screen, if you look in the 3 o'clock position, that's our clip, and if you look towards the top quadrants there, we'll see that this is us positioning our second clip going for a septal posterior leaflet grasp. We have the leaflet. We use our transgastric view to show leaflet insertion, a nice clover leaf appearance. Confirm with MPR, release clip. Got a really nice result in this case. And this is after implantation, significant reduction in tricuspid regurgitation. So just to briefly summarize, imaging for success, we have to see the leaflets, we have to know the leaflets, we have to be able to describe the leaflets, count the leaflets to guide our clipping strategy. We have to mind the gap. Our large gap patients are going to be difficult. Plan our grasp, be willing to abandon a position or regrasp if we are not liking what we're seeing, and with every move, anticipate what our next move will be during the case. Programmatic success, heart team dynamic, interest in advanced echo techniques, a willingness to learn, a willingness to push the bounds of what we're doing and train our sonographers to do so. Talented interventionists, of course, willingness to learn, comprehensive cardiology care, MOC clinic, and a patient-centered approach. And with that, I'll show a bibliography, and we'll move on to the next speaker. Thanks, everyone, for your attention.